So this is going to be a bit of a rush. This is the fastest I've ever tried to go through this topic, so we'll see how we do. I'm Dr. Zain Hakeem. I work at RiverRock Medical Clinic, and I'm talking about the correct interpretation of medical test accuracy using COVID-19 as an archetype because it's very much in the forefront of our consciousness. It's been interesting to me. I've been talking about this concept of Bayesian reasoning and Bayesian interpretation of medical testing for almost 10 years now. And it's interesting to see news articles coming out with terms like positive predictive value and negative predictive value, sensitivity, specificity, language that was very specific to this somewhat obscure statistical concept. And hopefully this will explain that concept in more detail. There are a lot of different medical tests related to COVID-19. Each one is slightly different than the other. And in particular, I think I want to highlight that today I'm not talking about the meaning of these tests. I'm only talking about test accuracy. And what I mean by saying that is that we might say, does a patient have antibodies? Now, if they do have antibodies, there's a separate question as to whether that means they are immune to COVID-19. If they are immune, then what do we do about that? If they're not immune, how do we manage that situation? We're not talking about any of those meanings today. We're only talking about the idea that if a test says that a patient has antibodies, or if a test says that a patient is positive for COVID antigen or COVID mRNA, what does that mean? Can we trust the test? How likely is it that that test is in fact correct? The other thing to keep in mind is that today's information can be very widely applied. It is actually applicable to all medical tests, and in fact, it's applicable to all forms of information gathering of the human species. All of science works on this principle. So we're using COVID-19 as our archetype, but it's pretty broadly applicable. COVID tests, and in fact, all lab tests have something in common, and that is that we are fundamentally detecting when something binds to part of something else. Enzymes work this way throughout biology. The shape of the enzyme matches the shape of the thing it's trying to bind to, and based on that shape matching, a chemical reaction occurs. We use those chemical reactions to detect what's happened, but in nature, nothing has perfect binding accuracy. Sometimes it binds something it shouldn't, sometimes it doesn't bind something it's supposed to. And based on those chemical inaccuracies, tests can have greater or lesser accuracy in their results. So I'm going to start by using an unrelated example, and that's just to get up to date on the mathematics. I know nobody loves mathematics necessarily, but the results of this kind of thinking are so counterintuitive that I find it is difficult to ask people to take it on faith. So we're going to walk through the example as quickly as possible, so at least you have some idea of where the mathematics comes from, and when I start talking about the consequences of thinking this way, you'll at least be able to trust that the math came from somewhere interpretable. So we're going to start by considering how to tell the difference between a lab-made diamond and a natural diamond. And hereafter, I'm going to talk about natural diamonds as real diamonds and lab-made diamonds as fake diamonds. That's not really, I don't love that nomenclature, but it's a lot easier to say. So in trying to tell the difference, we can use a microscope and a fluorescent scanner, as pictured here, to examine the fluorescence patterns within the gem. Natural diamonds have certain typical strain patterns as they're being formed under pressure, whereas synthetic or fake diamonds do not. We could, in keeping with the previous lecture, create an AI or a neural net and train it to recognize the difference in those fluorescent patterns so that that could be automated and no longer require a human technician. If we were to make such a device to detect real diamonds from fake diamonds, how would we know how accurate it was? After we've trained it, after we've taught the neural net, how do we know that it's doing what it's supposed to do? At the factory, we could do quality testing. So we could use this diamond detector. We could take a bag of 10,000 jewels, 100 of which were real diamonds, and 9,900 of which were fake. We run all 10,000 jewels through the device, and we see what mistakes it makes. Since we already know the answer ahead of time, we can pick up on when the device is making a mistake. So out of the real diamonds, this device that I'm hypothetically creating is very accurate. It only makes a mistake once out of 100 times. 99% of the time, it correctly calls real diamonds real. It is also very accurate for fake diamonds. 99% of the time, it calls fake diamonds fake. And I'm going to use this structure throughout the lecture. So on the outside here, fake diamonds and real diamonds, these are the correct results. On the inside, these are the incorrect results. So as you can see, two different types of accuracy, real and fake. For fake diamonds, 99% accurate. For real diamonds, 99% accurate. So now instead of running 10,000 joules, all of them through the device, what if I pick 1 joule at random from the bag? What's the chance that it's real? Well, it's pretty simple. It's 1%. 100 of the 10,000 joules are real, and that's 1% of what's in the bag. So before I do any testing, before I use the device, there's a 1% chance, and we call that the pre-test probability because it's before I run a test. Now, if I take that one diamond, which has a 1% chance of being real, and I run it through the detector. The detector pops out a readout, and the readout from the detector says, yes, it's real. Now what's the probability? Remember, this is a 99% accurate device. And most people, most doctors included, when talking about medical tests or the equivalent, would say that there's a 99% chance that it's real because the device is 99% accurate in both directions. And unfortunately, the math does not work that way at all. This is how the math actually works. What we do is we take all the times where the device says that it's real, and we figure out what fraction of the time the device is correct. So we take the number of times that the device says it's real and it's right, and we divide by the total number of times that the device says it's real. And what we get is that the device is right 50% of the time. Now, when I first learned this, I was pretty skeptical because I was like, wait a minute, we said this device was 99% accurate. And now you're telling me it's right 50% of the time. There's a mismatch there. How can a 99% accurate device be right only 50% of the time? And there's a specific case that helped me clear it up in my mind, and I hope it'll help you as well. And that is the case when there are 0 real diamonds. So if you start with a case where there are no real diamonds in the bag, all 10,000 are fake, then regardless of what happens, when you run it through the device and you do the math the exact same way, you end up with the fact that the device is right 0% of the time. And the reason is that every single time the device readout says real, it's from an error because there were no real diamonds. So all of the readings that indicate that the diamond is real are wrong because there was no way for the device to be right. So compare that, where it's 0% right, to the situation where when there's 1% pre-test, then the device is right 50% of the time. And what you start to realize is that part of the reason we get tripped up is that we're using the word accuracy in 2 different ways. On the one hand, when we say a test is 99% accurate, we're talking about these 2 values here. On the other hand, when we talk about a test's accuracy, we're talking about the final result down here. So those 2 different senses of the word accuracy result in quite a bit of confusion. And that's why a 99% accurate test can be right only 50% of the time. I'm going to start using more technical language here as we go forward. And I'm going to change from talking about the end result accuracy. I'm going to start calling that the post-test probability. That is that if the device says it's positive, or if the test is positive, what is the probability once you know that result? By contrast, these will be called sensitivity and specificity. It's not super important that you understand those terms, but you'll see them applied at different points throughout the lecture. So let's move on to beating this horse to death a different way, using a different visualization. So this is the same scenario where there are only 1% of the population has, in this case, a disease. So you can talk about diamonds or you can talk about diseases, but only 1% of the bag has what you're looking for. Again, 99% accurate, 99% accurate. And in this case, you can test one diamond or one patient at a time. And each time you test it, the test sorts people into negative or positive. And here, the blue dots do not have the disease, and the red dots do have the disease. And in an ideal world, all the blue dots would have negative tests, and all the red dots would have positive tests. And so you can test all 1,000. And you run the test over all 1,000, just like you were running through all 10,000 joules, and you get a very similar result. What you end up with is that out of all the times where this test says that it's positive, that the patient has the disease or that it is a real diamond, it's wrong half the time. So half of those answers are mistakes. Now, what if we give it a little bit of a fairer test? Instead of 1%, what if we give it 10% real diamonds, or by contrast, 10% of the time the patient actually has the disease? And again, you test all 1,000. And as you run through, what you'll immediately notice is that the test is performing better. So of all the positive results over here, a smaller number of them, a smaller percentage of them are due to errors, and a larger percentage of them are correct. We're going to look at that one more different way. So this is the same example, and again, this is a 1% pre-test probability. The sensitivity is 99%, the specificity is 99%, and a positive test, by the plus sign here, a positive test gives you a 50% chance that the joule is real. If by contrast you go up to 10%, then a positive test indicates a 91% chance that the joule is real. Now, a perfect test would do this. A perfect test would leave you in a situation where a positive test can absolutely be relied upon, and a negative test means that there's a 0% chance. So positive test, 100% chance, negative test, 0% chance, irrespective of what happens with the pretest. But even a slight inaccuracy, going from 99.999% down just to 99%, means that all of a sudden, at the edges, when things are rare, when there is a 1% chance or 1.5% chance of a real diamond or a real disease, then a positive test is a lot less reliable. And by contrast, when all of the joules are real, or when everyone has the disease, then a negative test becomes very questionable. And so as we go forward, I want to point out that I'll use a lower quality test here. This area here at the top of the blue box and this area here at the bottom of the pink box are the errors, just like the middle section of that diagram I showed earlier. And as a disease becomes more common, a positive test is more meaningful, is more accurate. As a disease becomes rarer, a positive test is less accurate and less meaningful. And the inverse is true for a negative test. So finally, we can move on to COVID. So if I were to take a random person in Travis County, current prevalence is around 2%, and there's lots of debates as to whether that's accurate or not, given asymptomatic cases, so on and so forth. We're going with the confirmed case rate just for illustration purposes. And I take a random person in Travis County and I give them a perfect test, a perfect PCR. Well, if the test is positive, then they have a 100% chance of having COVID. And if it's negative, they have a 0% chance of having COVID. But the real test is much less accurate. This is the accuracy, or again, I'm using accuracy as well. This is the sensitivity and specificity of a flu PCR. That's actually a best case scenario. According to the British Medical Journal, a more realistic accuracy of PCR is more like this. So with the 2% prevalence, a positive test really only gives you a 20% accuracy. So how do we deal with this? Even a really good version of the test, like flu, it's a coin flip. A positive test really gives you a 50-50 shot as to whether you actually have the disease. Well, what the CDC has recommended is that we start using symptom screening. So instead of just taking a random person, we take a random person and then we ask them, do you have a cough? Do you have a fever? Do you have loss of taste or smell? Do you have body aches? And so on and so forth. And someone with typical symptoms has almost a 50% chance of having COVID before you run a test. And in that case, as you can see, the discrimination between positive tests and negative tests is much more accurate. So there's a greater spread between the meaning of a positive test and a negative test. And for almost every other condition under the sun, this is exactly what you want. However, for COVID, that's not the case. For COVID, we don't want the most accurate result, I would argue. What we want is to minimize the false negatives, because these people got a PCR test and are going around saying, well, I tested negative, even though I don't feel well. You can come over and take care of me and give me chicken soup, mom, because I tested negative. I don't have corona. And so then grandma or ma can get infected because the test was wrong. So what we want is to make this number as small as possible, even at the cost of a great deal of false positives. And so our testing strategy actually needs to evolve relative to the goals we are trying to accomplish. So I would argue that the CDC's recommendations are actually counterintuitive or against our goals. And a better strategy would be to take everyone with symptoms and just have them quarantine without testing. No reason to leave unless you need to go to the hospital. Only people with one symptom, like just a cough, or people with just a risky exposure could get tested, or people who are at high risk of spreading the disease, healthcare workers, or even somebody who knows they're going to go visit their grandmother. That's a higher risk. And so you might quarantine yourself for 5 days, get a negative test, and okay, the antigen tests aren't that accurate, but at least you would lower your chance from 2% down to 0.5% before visiting grandma. That would also be a reasonable use of testing. I hope I've given you a flavor of how this kind of thinking works, is that you have to think about the context of who you are testing in order to decide what the results are. I'm going to give one more counterexample. If you have every single symptom of COVID-19 and your chest x-ray shows similar findings and your blood work shows similar findings, you have almost a 90% chance of having COVID. So even if the PCR says that you don't have COVID, a negative test is again not that meaningful. So it's really not worth running. If everything else screams that you have this disease, then a negative test is not reassuring. It doesn't let you off the hook. So where do we go from here? I think one of the main things I want you to take away from this is nuance, is that context matters. I've spent almost 20 minutes more than 20 minutes trying to explain this concept. There's no way to explain or think about this in 5-minute sound bites on CNN. It also means that we shouldn't throw the baby out with the bathwater. Yes, the tests are imperfect, but just because you have a screwdriver that's a little stripped, if that's the only screwdriver you have, you don't start trying to unscrew the screw with your fingers. You try to use an imperfect tool as best you can. And to do that, you have to understand what the tool is doing, how it's working, and how to apply it. And so just recognizing that everything is kind of in between and that everything in medicine, in testing, is imperfect doesn't mean that we can't use it. It does mean that we need to be skeptical. It means we need to doubt the results. If you get a positive result, say, maybe, what's the context? If you get a negative result, say, maybe, what's the context? But that doesn't mean you shrug and say, it's all inaccurate and we don't need to do it. I can ignore all the test results. It means that interpretation has to be done carefully by someone who understands the correct method of interpretation, which hopefully all of you now do. I think that's my time, so I can take questions.
Oh, that was great. Thank you so much. So we have our first question in for you, and I need to toggle over to the document. Dun, dun, dun. The question, it has a sub question in it, and if we were at the North Store, I would be like, no, one question, but fine now that we're online. So does getting multiple tests help reduce the odds of getting a false negative or a false sense of your condition? And if so, how many would give you greater than 99% confidence in the answer?
Great question. So this is actually an interesting topic. It uses what's called orthogonal testing. So just repeating the PCR doesn't necessarily improve accuracy, because unless the issue was a sample collection error. So we're not talking about that. We're just talking about the accuracy of the test. So let's say you have somebody, like I've specified here, 90% inaccurate, and you get a PCR that's negative. Now you're down to 39%. But if you just run another PCR, it's really not going to help you enough. But if you run a different test, then you can use that 39%, and I'm going to review that. So this 39% negative now becomes the pretest probability. And now I'm going to run an antigen test, which is a different type of test. And now I've reduced it from 39% down to 17%. So if and when we get very good quality antibody testing, we could stack that on, though the timing of that is tricky, and they seem to anywhere between 1 and 3 weeks turn positive, and then there's some indication they start becoming negative again after 3 months or maybe 5, somewhere in there. So tricky, but just for the sake of illustration, we could again take the negative value here and use that as our pretest, and then run an antibody test, and that would get you down lower than that hopefully that 99%. Now the probability after 3 different negative tests is less than 1%. You're really not going to do better than that. And honestly, that's probably a best case scenario. But it is possible to stack tests as long as they are different tests.
Awesome. All right. So let's see what else we've got here. How do you feel about the argument that a larger number of less accurate tests would yield more useful data?
Larger number of less accurate tests would yield more useful data. So yes, that there is some validity to that argument. Again, you have to define the word useful correctly. So if I take everyone in Travis County and I test them with a relatively inaccurate test, right? Then yes, if I test everyone, then the negative test works reasonably well, right? So mass rollout of even relatively inaccurate tests could work as a strategy, but you'd still have 0.5% of people rolling around with a negative test that would be infecting people because they tested negative. Again, the goal, I think, should be to minimize the negative predictive value, minimize the false negatives, which is saying the different way of saying the same thing. And both test accuracy and test strategy play in, but the wider the rollout, the smaller the pretest, just because you're taking a bigger pool of people. And that's one of the arguments in favor of a really massive rollout, is that the test becomes inactive. Now, and I will say this, you also run the risk, you're quarantining 80% of the positives falsely. So the positive test is very inaccurate when you do that. And a whole bunch of people are going to be falsely quarantined under that strategy. I think that if we're trying to control the spread, that may be a price we're willing to pay, but that is what you run into, is that's the flip side of the coin that you have to deal with.
So last question here. After you walk someone through the math, has anyone ever flat out refused to believe the Bayesian reasoning behind this testing strategy that you're supporting?
I don't know that this comes up at parties per se, but I mean, not that there are parties anymore. But no, I don't think I've had anybody outright refuse. I would argue that the kind of flat refusal that you're talking of, or that I've probably all experienced on one level or another, is more related to trust than science. I mean, you can explain something till you're blue in the face, but if the person doesn't trust you, then they don't trust what you're saying. And you run into the same thing with flat Earth arguments, for instance. Like you can say, well, look at the horizon, and the bottom of the object is disappearing before the top, so that indicates there's curvature. I mean, there are direct things you could do to indicate that the Earth is curved, but that's not really what you're arguing about. And if you continue kind of pushing the mathematical science explanation, you're missing the point. The point is really to figure out where you lost the person's trust. So that's a different discussion to be had.
Well, that's a very thoughtful note to wrap up on. Although I do have one final question that kind of goes with your last slide.
Sure.
When you're saying teach your doctor about this, if you could give someone like a little pocket, a little pocket prompt to take to their next doctor's appointment, what's the elevator summary that you would want someone to talk with their doctor about on this subject?
So I say relatively few understand this. That's partly true, but partly it's also that the current context of 12-minute visits doesn't allow for thoughtfulness. So, I have a luxury, in my practice format, all my visits are an hour long and I get to sit and talk, but that's not most doctors' context. And so most of the time it just takes a little push to say, well, this is the test result. What's the likelihood that's wrong? What's the likelihood that's a false positive? And at least get your doctor thinking back the way he was taught in med school and residency to think about false positives and false negatives. And even just that one question is, do you think this could be a false positive? And why or why not? Will at least get the topic started, I think.